So let's talk about diuretics. It's very important that we understand these because we give them a lot as nurses. So diuretics are going to accelerate the urine formation, the rate of urine formation. We're going to pull volume. We're going to diurese patients. We're going to remove sodium and water from our patients. And this, by doing this, they're used to treat hypertension, heart failure, and renal failure, renal disease. Okay, our kidneys are huge, guys. They play such a big role and an important role. That and the GI and GU, you need to know, they are the trash they're the trash wasters. They're the ones that come and take and filtrate and pull and get rid of all the waste and toxins in our body. It's either through urine or feces, but those two systems are what work for us with this. So it's so important to know that our kidneys filter the toxic waste, and the balance of them are maintained in the nephron. And this is important to think about because our nephrons as infants are not well developed. So we can have some issues there with filtration. And then with the elderly, as we age in that aging process, the nephrons aren't going to, we start to lose nephrons. So we don't have as many, and we can have decreased, the glomerulus cannot function or filtrate as well. And so we can have a lot of issues with filtration. And so elderly people, as we age in that process, we can have, we are not as, sorry for the we can't seem to filter as quickly. So if I give pain medicine to an elderly patient that say has chronic renal failure, so that means they're not filtrating correctly at all, they have a problem with that, then the medicine can't be processed through our body like it should. So it takes a lot longer to get through. So elderly people will hang on to pain medicines because of the renal function. So be very careful when medicating your elderly or your aging client or patient. The nephron is the main structural unit of the kidney. I'm not going to teach you anatomy and physiology again, but I do want you to note that. And I do want you to understand that the GFR, we can look at that. That is a lab value we can pull. And that's looking at the glomerular filtration rate, the GFR. That initial filtering takes place in the glomerulus. And as you learn in med-surg, there's a lot of disease processes where that can happen. One of the things that I want you to look at is the kidney structure itself. You have your proximal convoluted tubule, and it returns 60 to 70% of the sodium and water back, filtered back, fluid back into our bloodstream, back into our body. The loop of Henle comes down and it loops down, and you see it a lot. It's going to absorb 20 to 25% of the sodium. And because of that, this is where a lot of things can happen for our body and in this filtration event. And so that's why when we give a loop diuretic, we're going to have a potent diuresis here because of that 20 to 25% compared to your distal convoluted tubule. Notice that you're going to remaining 5 to 10% of sodium is reabsorbed here, and it is regulated by your aldosterone. So if I give a thiazide diuretic, I'm looking at a less potent and it's a more gentle diuretic. And you'll hear people talk about that or see that. So let's move on. Our overview pharmacology, just so you know, diuretics are classified by what's the sites of action within the nephron, their chemical structure, and their diuretic potency. And that's how they're classified. So we have different diuretics out there. Tonight, what I want to cover is loop diuretics. We have loop diuretics, potassium diuretics. Notice I highlighted in yellow the ones I want to cover, and thiazide and thiazide-like diuretics. I'm not really going to talk about the CAIs, the carbonic anhydrase inhibitors, but I want you to know they exist, and we will talk about them in another lecture. Also, your osmotic diuretics we'll talk about in another lecture. So our loop diuretics are what affect the filtration in the loop of Henle. So one of the things I want you to note by looking at the slide, you have the IDE, 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 right? When I see IDEs at the end of medications, I think loop diuretics. When I see IDE at the end. So we have Bumex or bumetanide. We have furosemide, Lasix, and furosemide Diuretics. Now, they're not all IDEs, just FYI, you will find others, and this is a perfect example. For my students, I really want you to know furosemide, Diuretics, Lasix, furosemide, and Bumex, that those are all loop diuretics. There's a couple things about the diuretics specific, like Lasix and Diuretics I will teach you. Those are the things I want you to know for testings, but I do want you to know in general what loop diuretics do. Okay, so mechanism of action. This is something interesting. They not only affect the kidney, they affect the cardiovascular and the metabolic system. So this takes place in this ascending limb of the loop of Henle. One of the things I want you to do, and I'm going to kind of explain it in a basic terms, I hope that it will help, is what happens when we give a loop diuretic. We have our system is filtrating. It's already filtrated, it's come down, and here we are. At this point, if there's no diuretic on board, our body's going to go, okay, let's reabsorb 20 to 25% of the sodium here, right? And fluid, because fluid and potassium, things will go back into our system to create homeostasis. So what happens is if we have co-transporters, so our co-transporters are sitting there waiting, we filtrate, and the sodium, potassium, and water and some other electrolytes get put up into the co-transporter, and the co-transporter is going to pull it over back into our system. So I think of co-transporters like little pickup trucks. They're going to I think transport trucks. We're going to have little pickup trucks. So where they're sitting down there waiting, doodly-doo, we put the sodium, potassium, and water in them, and then they're going to truck them on over back into our system. We give a loop diuretic, and it comes down, and it's in the loop of Henle. And when it comes down, it's going to go, We are not co-transporting today. We are going to offload the sodium, potassium, and the fluid that's been loaded into the back of the co-transporter and leave it in the filtrate. And by doing that, what's going to happen is it's going to process on through, and then we eliminate it out. Okay, so even though there will be some minor reabsorption of things, we have then held on to potassium and sodium and water into that filtrate, which means we'll have more urine. We'll have potassium and sodium in that urine. We're going to get rid of it. That's why loop diuretics are considered potassium wasters. You hold on to the potassium into the filtrate, and then we urinate the potassium out. So it's so important as nurses that we get a basic labs prior to giving our loop diuretic, because we need to know what our base level of potassium and sodium is before we ever give the diuretic. So we want to check that, because if we have a very low potassium, then we need to be, the doctor will need to give you an order to replace that potassium. If we have a very high potassium, we might be giving this loop diuretic in hopes to pull some of that potassium and get rid of it to give them a more normal potassium. Because if you have too low or too high of potassium, anything under 3.5 or greater than 5.0, it is hyper or hypokalemia, hypo or hyper, then we think cardiac. I want you to think cardiac, heart, because it's going to cause, it's going to affect the smooth muscle, and that can affect it'll cause dysrhythmias or arrhythmias of the heart, arrhythmias. So it's so important. The other thing a loop diuretic can do is it increases the renal prostaglandins, and that helps with dilation of blood vessels and reduces peripheral vascular resistance. By doing that, it's going to help our cardiac system, our cardiovascular system. It's going to help decrease the blood pressure and help with things moving smoother, because we are actually dilating blood vessels. It helps decrease the hypertension. And also we love to use this for edema. So that's why when this next slide we look at, you're going to understand why we use it. So it is the most potent diuretic. Ding, 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 underline it. Loop diuretics are the most potent. Think about it. If it's going to reabsorb 20 to 25% of the sodium, if we go in there and go, you're not doing that. Wherever sodium is, water's going to follow. So it holds onto the water, it holds onto the salt, and holds onto the potassium, and then we urinate it out. It is a lot. It's a big chunk compared to 5 to 10%, right? On the other side, on the other distal convoluted tubule. So it's a potent diuretic. We have subsequent loss of fluid. They urinate. So because of the decreased fluid volume, it's going to reduce our blood pressure. Like I said, the next 3 little bullets there, pulmonary, systemic, and central resistance are going to decrease. Central venous pressure will decrease, and left ventricular end diastolic pressure will reduce or decrease. And I want you to understand that, because left ventricular end diastolic pressure issues can cause that type of heart failure. So we love to give loop diuretics to heart failure patients, but, and there's always a but, it is a potassium and sodium depleter. Just like I said, when you think loop diuretic, think potassium waster. It's going to hold on to potassium and you're going to urinate it out. So what do you think as a nurse we should do? We should replace the potassium. So if you have a patient on a loop diuretic, you should always look at their lab value of potassium. When is the last time it's been drawn? Where is it? And are we replacing potassium? Now, if I have a chronic renal function or renal disease patient, they're going to hold on to potassium because they can't seem to filtrate it out. If that's the case, then we might give a loop diuretic in hopes to pull the potassium if we can, get it to stay so we can urinate it out and lower the potassium levels. Chronic renal failure patients don't always respond to diuretics. You might still see them given in hopes that we get a little something, but that's where dialysis will take place. We give them, once again, for edema associated with heart failure or hepatic or renal disease. We want to control hypertension. We give it to increase renal excretion of calcium for patients with hypercalcemia. So if we have a patient with a really high calcium level, we can give a loop diuretic to hopefully help it hold on to the calcium, and we can also get rid of it. In case of heart failure resulting from diastolic dysfunction. So if you looked at that prior slide, what it does, it decreases the end diastolic, left ventricular end diastolic pressure. Then that's with heart failure, we want to definitely give it to a patient with heart failure due to diastolic dysfunction. It's going to help them. Okay, I'm not going to go through all this. There's just a couple things I'm going to point out. It doesn't mean you don't need to know this. It's just I don't think everybody should read everything to you. You can read the slide. So central nervous, all the systems of medication, when you get a medication, no matter what it is going to affect the majority of the systems. It's in our body functions as a whole. So in the central nervous system, we can have dizziness, headache, tinnitus, blurred vision. GI, nausea, vomiting, diarrhea. But one of the things I want you to really look at is Stevens-Johnson syndrome with furosemide. That's our skin. If you don't know what that is or you've never seen it, look it up and look at images, and it's going to give you these pictures. It is life-threatening. So it is so vitally important that we look and pick up on that, especially when we're giving furosemide. It also affects the metabolic system, and that is where I want us to focus. It can cause hypokalemia, low potassium, hyperglycemia, high potassium, and hyperuricemia. So when we're looking at that, this can happen. Also with our blood, we can have thrombocytopenia or neutropenia and agranulocytosis. So it's important that you understand that these things can happen to the body when we take a loop diuretic. These are adverse effects. So it can be interactions, neurotoxic, nephrotoxic. It can increase serum levels of uric acid. That's what, let me back up. That's what hyperuricemia is uric acid, high uric acid. What do we think about an increase in uric acid? We think gout, don't we? We start to think that way. And also an increased serum level of glucose. So it can cause hyperglycemia and hyperuric acid levels. Thiazides if given sequential nephron blockade. So you're not only blocking at the loop of Henle with a loop diuretic. If I give a thiazide, I'm going to then at that distal part block also. It's going to create prevent reabsorption there of the water and the electrolytes. And NSAIDs can interact with loop diuretics. Lasix or furosemide is the most commonly used loop diuretic. We use it for pulmonary edema and edema associated associated with heart failure, liver disease, nephrotic syndrome, ascites, and hypertension. And I've kind of talked a little bit about all of those, but that is something you should know what we use it for. So if you have a client or a patient that comes in with edema associated with heart failure and the physician, what drug do you think the physician would most likely prescribed for this client? It would be a loop diuretic because we want to pull off the edema because of this. Okay, potassium sparing diuretics. So it does the opposite. It's going to spare these things. The one that I really want my students to know for right now, they're in their beginning nursing process of nursing school, is Aldactone or spironolactone. There are others out here. They're also known as aldosterone inhibiting diuretics. So when we think about that, aldosterone keeps sodium and will excrete potassium. So if you're using a potassium sparing diuretic, we're going to then inhibit aldosterone. So normally aldosterone will keep sodium and excrete potassium. It's going to do the opposite. It wants to hold on. It's not going to get rid of your potassium, but it's going to pull the other. It's going to pull the sodium, and where sodium is, water is going to follow. It works in the collecting ducts and distal convoluted tubule. It interferes with sodium-potassium exchange. So I love sodium and potassium, but I always compare them to a divorced couple that can't stand each other. When one's in the house, the other has to leave. So if sodium goes somewhere, potassium goes the opposite direction. They competitively bind to the aldosterone receptors and block reabsorption of sodium and water, usually induced by aldosterone. Because if they're going to block that reabsorption of sodium and water, it's going to stay in to be urinated out, and potassium will go back in. It's going to absorb potassium because where sodium is, potassium wants to go away. Now, I know that you think that's kind of confusing, but they're doing different things. So if I'm looking at the loop of Henle as a loop diuretic, it's coming down and it's blocking the co-transporters. It's blocking that system. So it doesn't take the sodium, potassium, and water and pull it back into our system, saying, no, we're blocking that. It's going to stay in, filtrate, and you'll urinate it out. That's why it's a potassium waster. This takes place down in the distal convoluted tubule. That's a very minor amount, right? We're not going to get as potent of a diuretic as a loop. But because of that, it's going to interfere with the sodium potassium exchange. And with aldosterone, if you think about aldosterone, it normally keeps sodium and will excrete potassium. But this medication is going to block reabsorption of the sodium and water. So wherever salt is, the water is going to stay, and potassium will then go away from it, because potassium doesn't want to be in the same house at this point with sodium. I hope that makes sense. Okay. It prevents potassium from being pumped into the tubule, thus preventing its secretion. It competitively blocks aldosterone receptors and inhibits their action, and promotes the excretion of sodium and water. So it's going to block sodium reabsorption, and water will stay wherever sodium is, and it is prevents potassium from being pulled into that system and urinated out. Okay. We look at Aldactone, or I can never say it, spironolactone, and we look at hyperaldosteronism. These are indications for hypertension. It's going to lower the blood pressure. It's going to versus potassium loss caused by potassium losing drugs. So if we don't need to lose potassium for whatever reason, then we can give this potassium sparing. But note, if we need to have a potent diuretic, the doctor's going to order a loop, and then you're going to replace potassium if needed. And then that is the only one I really want to talk about, and so that you understand what's going on. Okay. The potassium sparing diuretic adverse effects, once again, affect all. Notice that nausea, vomiting, diarrhea is normally in almost all adverse effects when you're looking at stuff. It is going to cause urinary frequency, weakness, and it can cause hyperkalemia. So because you're blocking the potassium from being dumped into that, it can create a high potassium level. And so you still need to get your lab levels and look at your potassium, sodium, your basic panel, and make sure that your potassium level is okay. Because if we have too much potassium and we're hyperkalemic over 5.0, we can have cardiac issue, dysrhythmias, and other things that can go awry. So just so you know, it can cause irregular periods, things like that. It does affect things. So that's kind of interesting. It's something that is an adverse effect too for females. Interactions. We never give a potassium sparing diuretic with lithium, people that take lithium. Our ACE inhibitors, potassium supplements, because we could cause, by giving potassium supplements and we're giving a potassium sparing diuretic, we can cause hyperkalemia that way. And NSAIDs. Yes, NSAIDs are always on that. Okay, let's talk thiazides for a minute. And I have some good info on thiazides. So thiazide diuretics usually have, hydrochlorothiazide. Sounds like this. These are still potassium wasters and chlorothiazide. These are diuryl. So thiazide like diuretics are these down here. The one that I really want you to know right now for my students is hydrochlorothiazide. I want you to be able to identify that, or chlorothiazide, either or. If you see those in a scenario or something, you understand that those are thiazides. And they sound like it, don't they? Thiazide, thiazide. They're pretty much there, aren't they? They're not all there, but those two are the thiazide diuretics. The thiazide-like diuretics, what happens or takes place are these. We're not going to learn or memorize or look at these at the moment, but just know that they're like a diuretic, like a thiazide. The thiazides have thiazide in their name, so you can identify. I went a long way to just say that. Sorry. Okay, they inhibit tubular reabsorption of sodium chloride and potassium ions. So once again, they're wasters. It takes place though in the distal convoluted tubule. Because of that, we're looking at a 5 to 10% reabsorption of sodium and water at that point in that filtration, unlike the 20 to 25% in the loop of Henle. So thiazides still are wasters of potassium and sodium, but it is a milder diuretic. It's not as potent as the loop because it's not as much filtration and reabsorption happening in that distal convoluted tubule. So we like them, and we like to combine thiazides with other medications to get a great effect for our patient. And you'll see that a lot. And we'll look at these here in a second. It does help dilate the arterioles by direct relaxation. So that is a good thing about a thiazide, and that's what we like about it. So once again, we'll pull fluids, diurese the patient, and decrease blood pressure. Okay, we'll have a lower peripheral vascular resistance. It can deplete sodium and water and potassium still at this point. We need to think about that, always getting our baseline lab values, knowing what our potassium, sodium levels are. And let me say this for nursing, you always want to look at your I's and O's. You need to know how much is going in exactly and how much is coming out to know that your diuretic is working correctly. And you don't want to dehydrate your patient. You need to make sure that they still have kidney function. Thiazide should not be used if the creatinine clearance is less than 30 to 50 mLs and a normal is 125 mLs a minute. That is something that you should know. Ding, ding, ding. Thiazides should not be used if the creatinine clearance is less than 30 to 50 when a normal is 125. And the other one down here, which is a thiazide-like one, is effective, but I don't want you to know that at this moment in time. I do want you to understand thiazide should not be used if the creatinine clearance is less than 30 to 50 mLs per minute. A normal is 125 milliliters a minute. Okay. This is indicated for, this is going to be indicated for hypertension, and it is one of the most prescribed drugs for this group. It is going to be given for hypertension. The thing that I want you to understand about thiazides is, and that's a ding, ding, ding right there. You need to know that loop diuretics are given for the most potent and given to heart failure patients, even though we're still going to use this for heart failure patients too, but it is a more mild diuretic and it is the most prescribed for hypertension. The next thing I want to look at on this is we give it for edema, of course. Okay. And then we look at idiopathic hypercalciuria, and we're looking at like different kinds of stones. Diabetes insipidus, heart failure caused by diastolic dysfunction, and adjunct drugs to treat edema related to heart failure, hepatic cirrhosis, corticosteroids, or estrogen therapy. I want to back up 1 second to this one. I want you to understand that when doing creatinine clearances, this is a lab that we get. It's a 24-hour urine collection. It's in 2 parts. We collect the urine over a 24-hour period of time and then having your blood drawn. These samples are then tested to see how much creatinine was filtered through the kidneys over a 24-hour window. So for my students, understand that thiazide should not be used if the creatinine clearance is less than 30 to 50 mLs per minute. Okay, once again, they have adverse effects. When we look at that, genitourinary, it can cause impotence. So let me say this, if you have hypertension and you're getting thiazide diuretics, it can cause impotence. This can become a big, big issue with younger men that have hypertension. They want to be sexually active, and this is something you should understand, and they need to understand. They don't need to know that something's wrong. So if you're giving a thiazide diuretic, one of your nursing teaching moments needs to be something to say, if this happens, please let us know. And it is a side effect of the medication. Of course, nausea, vomiting, and diarrhea. You can never go wrong with those. For this diuretic, once again, hypokalemia, which is low potassium, hyperglycemia, which is high blood sugar, high uric acid, and hypothalamic alkalosis. The one thing I want you to understand that the thiazides are still potassium wasters and can cause increased blood sugars, glucose levels. Okay. Thiazides also, what I want you to know is they don't really know why they cause hyperglycemia. They think that it has to do with once you have a volume, the catecholamine release secondary to volume depletion, when you pull that volume off with the diuretic, it can inhibit insulin release from the body, and because of that, you can have a higher blood sugar. They think that might be what causes it. It is mainly used to treat high blood pressure. They'll occasionally use it for heart failure. Loop diuretics are the heart failure drugs of choice, or the diuretic for heart failure. And normally when used, they can give thiazides with the loop with heart failure patients. So duo diuretics. So if you have a patient with diabetes, do you think we should be concerned about giving thiazide drugs? Yes, we should, because it could cause hyperglycemia. So that is a thought that we need to think about. We need to really watch our blood sugars. The other thing we need to know with this is it can increase the level of uric acid. If that's the case, if you have gout, you may have more gout attacks, because the first attack of gout is sometimes triggered by taking a diuretic. So some people can take diuretics and then they can get gout because it's going to trigger it, because they've got, all of a sudden they might have had a very mild case of gout, but they're not even aware they have. And then all of a sudden they have an influx of uric acid, and it can cause this gout inflammation. We have upset stomach. We talked about all that. The one thing that I find interesting about it is it can cause excretion problems with an impotence. It's often reversible of stopping the treatment. So with the impotence of a patient or client, if they start the medicine, they usually don't have any problems sexually. I have a very dear friend that's a very young gentleman that got severe hypertension, and he was married, had children, and the concern for him was the problems on the sexual end of that. And he would stop taking his hypertensive medications so that he could be sexually intimate with his wife. But in the meantime, the havoc, the blood pressure, high blood pressure, is what it's doing to the body is just horrible. So it's like he had to make a choice. Did he want to be able to be sexual with his wife or have his blood pressure controlled? He chose sexuality with his wife, sexual intercourse with his wife, over the blood pressure, but then he would get back on it, trying to control it. So it is something to think about, and it's something as a nurse that you need to think about, especially with younger people. Let me think. So it does also affect, thiazide drugs will also affect calcium. So I find that interesting. So we can have hypercalcemia with thiazide drugs. Because of that, we need to think dietary. How are we don't need them to be pulling in a bunch of calcium enriched foods or calcium supplements or anything to increase the calcium anymore. So one of the things I pulled and I want to share with you are, always tell your patient to look for fortified foods with calcium and vitamin D. Orange juice instant, oatmeal, breakfast cereals, calcium fortified breads, soy milk, waffles, juices. Read the labels. Those can be fortified with calcium and vitamin D a lot, and they don't need it if they're taking a thiazide diuretic. The other thing to avoid is salmon, tofu. High in calcium foods are salmon, tofu, sardines, spinach, broccoli, Brussels sprouts. I love them. Navy beans, bok choy, almonds, rhubarb, turnip greens, sesame seeds, white beans, kale, corn tortillas, mustard greens, and oysters. Make sure they read the labels. And I'm going to say to my students, take your notepad and jot some of those foods down. You might see those and for testing purposes, because one of the things as nurses is we need to be able to identify foods and talk nutrition with our patient or client, especially when they're taking different medications. Okay. Nursing implications. Let's go through this kind of quickly and I'll wrap this up. You want to perform a thorough patient history and physical exam always. You are only as good as your assessment. Just know that. As a nurse, you are only as good as your assessment. If you don't assess or you're not good at it, you're not a very good nurse. And I'm just going to go on record to say that. And I've seen both sides of it. Assess your baseline fluid volume status, intake and output, serum electrolyte values, weight, and vital signs. We want to weigh our patients. If they're a heart failure patient, we always know to weigh. Same time, same scale, same clothing. And the best time is in the morning after they've fasted. When they wake up, use the restroom. Eliminate their urine and feces if they can, at least their urine, and then get on the scale and track it. If they have a 2-pound weight gain in 24 hours or a 5 to 7 pound weight gain or a 5-pound weight gain in 7 days, they need to contact the physician. That is not good or normal. Assess for any disorders that may contraindicate or necessitate cautious use for these drugs. Always instruct your patients to take the medication in the morning if possible to avoid interference with sleep patterns. So if we're giving these, the reason why we want them to take them in the morning is for safety. You don't want someone to have to get up all night breaking their sleep, especially elderly people. What are they going to do? Trip and fall? It's dark, they can be confused. So even myself, I have struggle in the night getting up sometimes. I can trip over stuff and all. So you want to make sure, and you want people to get rest. It's important. They need to sleep when it's time to sleep. So take your diuretic in the morning, urinate let it do its thing all day long, and then hopefully by the time it's time to go to bed, you're done with that. You can sleep and rest and not have to get up multiple times through the night. Okay, monitor your serum potassium levels during therapy, always, 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 even if it's high or low or normal, monitor, because you are wasting or holding on to and can cause hypo or hyperkalemia. Okay, teach patients to maintain proper nutritional and fluid volume status. Always teach patients to eat more potassium-rich foods when taking any but potassium-sparing drugs. So if they're taking any diuretics besides a potassium-sparing drug, they need to learn to eat potassium-enriched foods. Foods high in potassium, ding, 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 bananas, we all know that. We're taught that at a very young age. Oranges, dates, apricots, raisins are a good one. Broccoli, a good one. Green beans, potatoes, meats, fish, and legumes. I like dietary questions, guys, and you know it. I think we need to know these things. It's important because patients and clients need to know this, and it's difficult. I think nutrition is very difficult these days. We have too many choices and too much easy access, and it's very difficult to know what's in your food. Patients taking diuretics along with digitalis or digoxin preparation should be taught to monitor for digitalis toxicity. So we need to worry about dig toxicity. What's the #1 sign or symptom of dig toxicity that we see? We see visual disturbances and halos around, green or yellow halos around lights. Should know. If I'm given dig, if I'm dig toxic, this is what I see. Patients with diabetes mellitus who are taking thiazide or loop diuretics should be told to monitor blood glucose and watch for elevated levels. Both loop and thiazides will increase the blood glucose levels. They can. So ding, 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 you need to know that. And what are we going to do with our diabetic patients? If they're taking this stuff at home, they need to check their blood sugars. If they're in a clinical setting, we need to check their blood sugars and make sure that we're monitoring that. Okay. Teach patients to change position slowly because we worry about orthostatic hypotension. So we want to have them sit up on the edge of the bed. They can pump their feet because we're pulling volume. And one of the things when we pull volume is we can create an orthostatic hypotensive state. So we want to be very careful with that. We want to encourage our patients to weigh daily, and I just talked about that, and remind our patients to return for a follow-up visit and lab work always. A lot of people want to go home, take their drugs, and never come back to the doctors or go get their labs drawn, but they need to. We need to monitor. It is so vitally important for their health. Okay, they can be ill with nausea, vomiting, and diarrhea. If that's the case, notify their primary care provider because fluid and electrolyte imbalances can result. So we know if we throw up or if there's vomit, we're thinking metabolic alkalosis. And if we have diarrhea, we're thinking metabolic acidosis. And both of those, we can lose our electrolytes and cause imbalances. So it's important if we have any of these issues, tell them to call the physician. Signs and symptoms of hypokalemia include muscle weakness, constipation, irregular pulse rate, and overall feeling lethargic. Hypokalemic. For my students, I want you to highlight that and be able to know that if I have a hypokalemia state, I've got a decrease, an irregular pulse, because that's my arrhythmias, right? I can have an irregular pulse. I have I'm just a big slug, aren't I? I have muscle weakness. I can have constipation. That's a big thing, guys. And just feel lethargic. I know that feeling. Okay, instruct our patients to notify their doctor if they experience a rapid heart rate or syncope that can reflect hypotension or fluid loss. So if they have any flutters, any rapid racing heart rate, anything, if they have a fainting type spell, something like that, they need to call their physician immediately, because there could be a major issue going on with electrolytes or just volume status. Excessive consumption of licorice can lead to an additive hypokalemia in patients taking thiazides. This is a ding, ding, ding moment. This is something that you just need, just put it in there. It's one of those things that you won't forget. You know what I mean? Licorice can lead to hypokalemia if you're taking thiazides. I do want you to know that. Not that a lot of people eat licorice anymore, but it is something important to know. So, if we're looking at adverse effects, they can go into metabolic alkalosis, drowsiness, lethargy, hypokalemia, where we're losing our potassium, tachycardia, hypotension, leg cramps, restlessness, decreased mental alertness. Decreased mental alertness can come with sodium and potassium irregularities if we have too low or too high of those. Monitor for hyperkalemia with potassium sparing diuretics. Ding, ding, ding. Okay. It's going to reduce edema. We're going to monitor this. Reduction of fluid volume overload. So if they have crackles, if they have a lot of swelling, we should see a decrease of these things, or it improving. Improvement of heart failure manifestations, reduction of hypertension, our blood pressure should come down, return to normal intraocular pressures. If we had a high blood pressure and we're giving, but you don't need to know that right away. That goes with some of our other diuretics. Okay. I'm not doing that. And that wraps it up. I know it's a lot of information. It's been said in class several times. I want you just to listen, take notes, and think about it. Critically think things through. Don't let fluid and electrolytes overwhelm you, because it doesn't have to be overwhelming. Just think it through and make it to where you understand it. You're going to be great nurses.